Hello everybody. Welcome, my name is Mark Upton and welcome to Ask the Expert. I'm here with Gurjeet Jutley from the Oxford Eye Hospital. Welcome Gurjeet. Thank you so much for coming and joining us. I know you're extremely busy at the moment, particularly at the present situation. So thank you so much for taking time out to answer people's questions and be a part of this. So we're from Oxfordshire Association for the Blind, and this is your questions for Gurjeet. And Gurjeet, I wonder if we could start off just maybe explain a little bit about who you are, and then I'll sort of start firing some questions at you, if that's okay.
Sure. Thanks for the invite, Mark. I really appreciate it. Hi, everyone. I thought I'd take the opportunity to sit outside, enjoy this sun whilst it's still here. So essentially, my name's Gurjeet Jutley. I work at the John Radcliffe predominantly. I'm a consultant ophthalmologist. I subspecialise in the front part of the eye, particularly with cataracts and glaucoma. And I've had links with the OAB in the 3 years that I've been here in Oxford, and we've worked together closely to try to help patients with severely sight impaired in terms of both sort of physical, mental and psychological support for all of those kind of patients who need it. So it's a pleasure to be here, and it's great to be affiliated with this such fantastic endeavour.
Fantastic. Shall I start us off then? So if you don't mind, maybe explaining a little bit about how COVID-19 has affected eye care services and what's changed now for those who haven't maybe been to the eye hospital. What's it like? How different is it, and what will people expect?
I think this is something that we've all got concerns and worries about. COVID-19 has had a massive impact on our healthcare, and I'll stick to ophthalmology in the main. So essentially, prior to this pandemic occurring, we were streamlining and sort of trying to stratify our patients to high, medium and low risk patients, so we could ensure that the right people were seen by the right healthcare professionals. And COVID's kind of fast-tracked that a bit more. So essentially, from March to August, essentially everything was pretty much shut down, and it was extremely challenging for us to ensure that all were well and we were able to meet their needs. So as the core consultant body, we were doing emergencies only, whether that be surgical, whether that was medical in terms of casualty services, and looking at patients on the ward that were admitted with eye conditions. So from probably March till about May, we were doing just that, and some of our doctors were deployed elsewhere. From May onwards, we started bringing back late May, early June, semi-elective work, the high-risk glaucoma patients, the high-risk cataract patients, etc. So we started bringing that kind of service back. However, we're very mindful of the restrictions that were in place, particularly by the government in terms of social distancing. So currently what we try to do is ensure that patients are triaged based on their risk factors, and those patients that can be seen remotely, we do. We're utilising virtual services more and more, where patients are brought in for all the investigations and a doctor looks at them remotely. Furthermore, we're doing more sort of virtual assessments where the patient and doctor are communicating through electronic modes like this. And we are seeing high-risk patients or medium-risk patients in the clinical setting, mindful of social distancing and mindful that potentially that these patients will need more intense follow-up regime. So, for example, if we're doing surgery in a patient, they will be for example, required to come in on a weekly basis. So these are the kind of changes that we've seen in the eye department, and of course that has led to a degree of anxiety amongst colleagues in the hospital, because we don't want to miss something or lose one of our patients, but
Of
and also
course, yeah.
the community as well on the other side of the fence. Occasionally we get a lot of queries from community doctors, general practitioners, opticians, and quite rightly, what's happening with that patient. It's an extremely tricky situation.
Yeah. Can I ask a very ignorant question here, Gurjeet? In terms of the remote assessments, how much can a doctor tell? I mean, can a doctor see the back of a person's eye through sort of a smartphone camera, or how much can they actually look at? Is it possible to pick up issues that way?
This is a great question, Mark. Essentially, remember the ophthalmology, there's a degree of oculoplastics, there's a degree of neurology. So certain conditions like ocular motility or lid or orbit problems can be assessed, and pathology can be ascertained in a remote manner. But you're right, by and large, majority of ophthalmology intraocularly into the eye can only be done utilizing clinical examination and investigation modalities. And we're lucky at the JL, we've got an amazing imaging service, and whereby patients can come in, not quite outside hours, but certainly when there's less clinics running or designated clinics to a virtual setup, whereby these patients can go and have imaging done, and then the doctor then looks at these images, and the fantastic camera work that we have and the fantastic investigation modalities like scanning at the back of the eye, the doctor basically has all the information to make a diagnosis to a great degree. So it's certainly possible to do these virtual endeavours, and quite rightly being utilised to minimise high-risk patients sitting around in the hospital where possible.
Okay. And I know you touched briefly there on surgeries. Has it affected the way you are doing surgeries now? Are you not able to do as many? I know a lot of sort of surgeries have been postponed at the beginning. What's happening now? Are things picking up, or is it still similar situation?
I mean, we're trying to do more surgery because we recognise patients have been waiting, and even things like cataract, which we deem as an elective procedure, because patients have been waiting now. They're losing their ability to drive, for instance, or losing quality of life. So we recognise this, and other patients who are HGV drivers, for example, their livelihood is at stake. So we are trying to do as much as possible, but there are other factors to consider. Patients who haven't sought medical help for obvious reasons in the pandemic may have poor systemic blood pressure or diabetes, and as a consequence we don't want to do elective procedures which could sort of have an impact systemically and ocularly. Second of all, we need a swab system. They need to be negative, they need to be shielding and isolated in order not to endanger other patients and also staff themselves. We have to be mindful that we're ensuring that there's, I mean, not to say that we weren't adhering to strict hygiene prior to it, but that's been ramped up with measures, particularly if patients are having anesthesia. So all in all, we're definitely not down up to the capacity we were prior, but we're trying our best. And the endeavours of our service, the head and neck service, and our sort of clinical leads are attempting to get things up and running, particularly as we all are conscious that this needs to be done.
Thank you. What would you say to somebody, say somebody's had their surgery postponed or cancelled, and they're concerned, they've got a concern maybe about a change, and they don't have a future date? What's the best route for a person to go? Should they just call the eye hospital? What would you suggest? What's the recommendation?
It's a real tricky one. I mean, there are certain symptoms that are acutely sight-threatening. Sudden loss of vision, flashing light floaters, these kind of things that do transpire. We've got to think actually this could be a permanent loss of sight potentially, and this patient needs to be seen in the casualty service. Conversely, if we know you have a pathology, if you know you have a pathology, for example, a cataract, and you're on the waiting list, unfortunately, at this moment in time, those elective procedures will be delayed, bearing in mind that others, who have advanced glaucoma or a retinal detachment, they will take priority. So I think the first thing to do is there's always help. There are designated email addresses or phone lines that one can ring, but please be mindful that it's going to be inundated, and if it's, a patient who has sight-threatening disease and potentially is not so aggressive in seeking help, may miss out and have dangerous repercussions if that's exhausted with other queries. But there's always help amongst your opticians, the GPs. There is an emergency service running, but this hasn't stopped since COVID, so it's always there. But we're also mindful our patients are very kind and generous in the sense that they will try to triage themselves as much as possible. But help is always there in one way or another.
That's good to hear. Thank you. Change slightly direction in terms of the actual appointments now at the we're obviously specifically talking about the John Radcliffe Hospital in Oxford. I know for myself, I've been in a few times since lockdown. What can people expect now in terms of changes? I know you have to come in on your own if you can't come in with a partner. What other changes can you say, or is it changing a lot? So it's hard to say, really.
Yeah, no, I think it's a continual evolving process. I'm very passionate and proud to work at the JR. I think it's an amazing service that we provide. And pre-COVID, we were quite efficient anyhow. But as you know, that we were seeing a high volume of patients. So there was our patients understood that they were getting an amazing service and were happy and kind enough to wait. We're trying to streamline patients now, so patients are not waiting as much. There's less space for waiting. We have designated pathways, so patients are fully in a process to increase efficiency from having the initial investigations to be seen by a doctor or a healthcare professional to leave as quick as possible. So I think the efficiency is improved, but at expense of numbers. So we're seeing less people are accompanying patients, and we're also mindful that before you enter the hospital that you will be screened to ascertain if there's any concerning symptoms or signs that you're displaying in terms of your systemic health, bearing in mind that there's a pandemic.
Brilliant, thank you. And just to save self, absolutely fantastic service when I've been in throughout the whole of pandemic. Every now and again I had to go in and saw the changes go on and saw how the staff managed to cope and adapt and still have a smile on their face, still offering guiding if anybody's anxiety about that. The staff will still support you from door to...
Having worked in many hospitals in the UK and indeed the world, I'm really very proud to work at the Oxford family. It's literally that is a family service that we offer, and be part of it.
Yeah, it's great. Before we get into any specifics, I just want to ask a bit of a broad question, if that's okay. What do you feel the effects of COVID will have on eye care in the future? Do you think we keep talking about the new normal and how things are now adapting and changing? Is there anything that has changed for the good, to start with some positives, and what are the obvious negatives that are going to affect eye care and eye services?
I think it's a difficult question, Mark. The first thing is, of course, things have become more efficient. I keep using that word efficient, but patients who, essentially needed reassurance, and that was their objective of coming to the hospital without evolving pathology, to have a service whereby we are now utilising a virtual service whereby they may not necessarily be seen by a doctor yet. They have all the investigations done. By maximising this resource, we are then truly seeing the patients that need to be seen. So that's a plus.
And do you think that will remain the virtual sort of
Definitely.
screening?
I've
Great.
been for 3 years, and we evolved that service
Okay.
around that time frame, but it's just now being utilised.
Sped up. Yeah. Yeah.
So
Right.
that's patients who are used to coming in, they might find that process and that transition a little bit tricky. However, the caveat is that a doctor will always see the results, and if there's anything concerning, the patient will be brought to our attention sooner rather than later. So that's a positive. We are now fully paperless, so all the EPR records are being utilised. So, for example, in my team, we now use the EPR system whereby you can access that from anywhere in the trust, meaning that we're not reliant on lost notes or anything like that, because all the records now are electronic. Our training hasn't suffered, so doctors are still coming in, so we've got a high caliber of training, right, as well as our teaching program has now gone remotely, meaning that doctors don't need to be wasting time on their travels from other centres to have the benefit of the experienced consultants at the JR. So I think there's a lot of positives. But in this, I also recognise having family members, my mum being patients on the other side of the fence. There's a degree of anxiety which potentially need not be, which can be alleviated by modalities like this, to say actually here are the changes we're implementing, and we're aiming to be as efficient with utilising our resources that we have to ensure that you have the best care. Now, of course, in this horrible time period, there will be patients that may not be seen timely, and part of my role as the governance lead is that we are looking at these patients who have missed appointments and how we can expedite them, and maybe expand our shared care health, whereby you may not necessarily be seen by a doctor, but you will be seen by a healthcare professional. So there are modalities that we are exploring, but we also recognise that it's a challenging time.
Yeah, of course. Thank you. We're going to go into a few specifics now, and I have to say to everyone watching out there, we haven't had a chance really to go through these beforehand, so I am sort of throwing these at Gurjeet, so thank you for taking them on the spot. We're going to start with a question which came through quite specific, but basically we have a gentleman who has had and apologies for my terrible pronunciations of these medical terms, but a trabeculoplasty in his right eye, and he hasn't had a follow-up appointment after a year, so he's a bit concerned about that. And is that the way to go forward? Does he need to sort of push for a follow-up appointment? What would you say on that?
I think from what you've said, Mark, it sounds like, well, first of all, I'm not going to mention specifics. Thank you very much for letting me know that. But there's trabeculoplasty is a selective laser treatment, SLT. Essentially, it's a procedure for glaucoma. If you think about glaucoma as, this is going to be very simplistic, but a imbalance of pressure. There's too much pressure in the eye. We can treat, and in a contained structure, pressure is proportional to volume. So we either reduce the fluid being produced in the eye, or we help fluid drain out of the eye. An SLT procedure is to do the latter, whereby you're using laser to make holes in the porous drainage system of the eye, and those holes expand so fluid can drain. So it's utilizing the normal pathway of fluid drainage in the eye. It's debatable who uses what, i.e. which doctor will opt to use SLT. In my practice, we don't use it as much as others, for example.
Okay.
However, it's usually done in an early path of the pathology, i.e. in patients who don't have advanced disease. And it might be done to save a patient from using a drop or to reduce the drop burden. Or so essentially, yes, a follow-up is required after SLT. That's normal practice. And in a situation, hypothetically, if let's say I did an SLT and I couldn't see the patient for 2 years, the safest thing to do in that situation would be to recommence a drop, so that if there is no effect of the laser or the laser's worn off, optimal safety is preserved by utilizing the drop.
Okay. And is that on the, just to try and help this person a bit more, is that on the basis of vision changing, or what would you suggest they do in terms of a follow-up? Is it a case of just waiting?
So if one if one has SLT and a follow-up hypothetically would not be given, vision is a bad parameter to assess.
Okay.
There's been damage or lack of efficacy of the laser. In a situation whereby you haven't been seen for such a long time, if, for example, if I hadn't been seen for such a long time, it'd be sensible to communicate with someone, whether it be the GP or the eye surgeon. From our side, from the JR in the glaucoma service, we are looking at each patient's notes. We are triaging that patient's notes to
Okay.
risk factors. So we are stratifying. That's all I can mention about that.
Yeah, no, that's fine, and that clarifies also what you were saying at the beginning about the triage as well. So, if they do get in touch, obviously it will be looked into. So that's good to know. I'll follow up now with another question. So I've got somebody's written in here. So when I am tired or in bright light, I see flashing light in my eyes. This seems to float around. What are they, and how are they? Are they something to be concerned about? So there's no other specifics on the condition or anything, but
yeah. So the way the eye sees is that light rays from the environment are bent by two structures, the cornea and the lens, onto our retina. And the retina has 9 layers, and that information is transmitted by rays to electrical energy that's transmitted to our brain, so we interpret an image. So when the retina is stimulated by light, we see an image, essentially. Occasionally that can be done through mechanical forces. So inside the retina have jelly in the eye, a vitreous humor or jelly, and sometimes if that's tugging, it's stimulating those cells, so you're perceiving a flashing light even though there's no light rays in the environment. So if one is seeing flashing lights, our worry is that it's something else, and a differential diagnosis just thrown out there would be things like migraine or the jelly tugging, which can pull off totally, which we call a vitreous detachment. And occasionally if there's adherence to the retina in abnormal locations, that can pull a little bit of the retina off, where we get retinal breaks, tears or detachments. There are other inflammatory conditions that we look at, the so-called white dot syndromes, which can also present like so. So essentially, flashing lights is a symptom that we do take seriously, and that needs to be seen. The caveat to that, if one has had flashing lights for decades, for example, likelihood that something terrible evolving is low. However, still needs to be seen.
Okay, and I mean, even if so, this particular person has an ongoing eye condition. Could it be something to do with that eye condition, or don't know really? It's just
comment, and I wouldn't like to comment on.
Yeah. Okay. I'll move on to the next question now. So this same person actually says, by the end of the day, my eyes get tired. Is this something that will affect my long-term visual acuity? So,
it's a vague symptom, tiredness. In modern life, we're staring at screens all day. We're in air conditioning. We're wearing masks now all day. It's an uncomfortable situation. So the lack of blinking and dry eyes can be a factor to cause people to rub their eyes more, for example. In the pollen season, we've had a particularly nice month.
Yeah.
And allergic responses as well. So it's as a general rule, unless there's other underlying conditions, sort of fatigue at the end of the day of the eyes is not going to have a massive impact later in life.
Yeah. So next question, I'll read this out in full because it's a little bit long, but so it says, does it make a difference to intraocular pressure control if one administers eye drops at the exact times in morning and evening, for example, 9 a.m. and 9 p.m? Or can there be room for flexibility? And if so, how much? And it says, in the morning, is it better to administer drops before one has gotten up and out of bed and still rested? Or if this doesn't make a difference and one is out of bed, is it better to administer medication before, say, first cup of tea or coffee?
Really long question.
Yeah, really long, but I think almost, sorry. So the first part is, does it make a difference to when they administer their drops at the exact same time of day? So, for instance, 9 a.m. and 9 p.m.
So there's two principles about that. One is there's a diurnal variation of pressure, i.e. the pressure throughout the day, and that's why sometimes a one-off pressure reading in the clinic can be, sort of falsely reassuring or falsely sinister, because you have to look at the whole picture, and investigations are important. But anyhow, it's quite well recognized the highest peak in pressure is sort of in the night time at 2 a.m., for example. And so if you're using drops that take a little while to become effective, the best time to instill these drops between 9 and 10 p.m., something like that. Okay. So that's to put your nighttime drops in. And second part is that these drugs have half-lives. So as a consequence, in an ideal world, if you're supposed to take it, twice a day, it makes sense to set a time at, let's say, 9 a.m. and 9 p.m. However, we also have to recognize that we're not robots, we're human beings, and we have other responsibilities and other sort of preoccupations or other tasks to do. So as a consequence, whilst one tries to ensure that a timetable is upheld, it may not be possible, and if that's the case, try to do it the following day.
Okay. Their other point was, is it better to do it before you're up and out of bed, and you're still rested? Does that make a difference if you're still rested to the administering of drops?
I would say still rested. However, if you're sort of lying down in a supine position, so you're in bed, you face up to the ceiling, you can put your eyelid down and then help instill the drop. And we've done a lot of work with Subhash for drop installation techniques, and I think that will help sometimes patients to put the eye correctly into the drop correctly into the eye.
Okay, thank you. We're going to move on now to a few eye health related questions. So the first one, which is obviously quite an interesting one, is what supplements can you take to help your eyes? Are there any?
Supplements. So let's talk about three broad categories, let's say. So for glaucoma, there's some evidence out there that ginseng is neuroprotective. So in patients with advanced glaucoma, that's a sensible thing to utilize. In dry eye patients, the caliber of the tear film can be changed by taking things like omega-3 and flaxseed oil. And if you think about the retina disease, there was a large study, the ARED study, which suggested certain vitamins that now come in components for certain patients are sensible. So you got places like Holland, healthcare shops that will sell these vitamin combined complexes that could potentially be beneficial in certain types of patients. But just remember, as is a golden rule for all of us in any type of walks of life, is that the healthier we are, and a little bit more exercise, less alcohol, better diet, green leafy vegetables, that's far more beneficial systemically and ocularly.
Thank you. In fact, we've got this question coming up, so I'll ask it now. Any food groups which you recommend? You said green leafy vegetables. Any other sort of recommendations for good sort of eye health that can help?
For example, if one is diabetic or hypertensive, that has a massive impact in ocular pathology. So, sort of cutting out all the sugary foods and salty foods is very easy for me to say, but it's hard to do. And it's just the small changes in lifestyle that's always sensible. Sort of kale, spinach, you never can go wrong for your macular and for your general health if you're eating such a varied diet.
Okay. There's a specific one here. I've heard that vitamin A can help with Stargardt's disease. Can you elaborate? I don't know if you've come across this. Or is it just a general?
Was that vitamin A is slightly more detrimental in Stargardt's disease, and it's something that colleagues would recommend avoiding in terms of supplementation. However, I wouldn't like to put my hat on that, and I'd have to look that up, but my understanding generally is that it's detrimental taking supplementation of vitamin A in Stargardt's.
Yeah, I think we'll talk to the person, maybe look into that further, and yeah, that's fine. Thank you. Now, this is the big question that quite a few people have asked. Can you damage your eyes by looking too much at a computer screen, smartphone or tablet?
Right.
Everybody's doing this at the moment, particularly with working at home, lots of screen time. So what are the risks or not? Or
look, I think, my niece and nephew are quite young, and I try to not let them look at too much screens. Why? In children, it's never a good idea, and you've got higher risks of myopia or short-sightedness. But from an adult population, you're not going to damage your eyes per se by looking at these electronic devices. It's not great for overall mental health. It's quite important to have shutdown time and me time. The only worry would be is that people don't blink so much, so they get dry eyes. If you have a refractive error, it's not been assessed by your opticians, which is important to do. It's really important to go to your opticians, and we're quite lucky that we work quite closely with our amazing opticians in the community, Oxfordshire. But if there is a refractive error and you're straining and you get symptoms of asthenopia, that can be, you get a headache at the end of the day, and that's again not overly desirable in general life. So I think I'd say my message is, and we were doing this quite strictly with my team, was that, look, here is your time to use whatever device for work, for pleasure, and then off time, go in the garden, go for a walk.
So sort of change your focus, I guess, on something else. Yeah.
Or whatever. And it's certainly people who, like myself, we didn't really have IT at school, so we weren't really habituated in using it, and we were using more books and encyclopedias, etc. Nowadays, even school has changed, and it's very important, I would say, is that cut-off time and that break-off time is preserved.
Great. And I think you pretty much answered this, but the next question is, can you damage your eyes by trying to look at things which you can't see that well too much? So if somebody's got a visual impairment and they're straining their vision, can that be damaging?
Um, Not necessarily, Mark. I think it's a source of frustration and
Mm,
anxiety. It's a source of helplessness because you're not able to achieve your tasks. And
mm,
I've have had many patients over the years who are bright academic who that kind of loss of ability to read takes away their pleasure or sort of,
mm,
but by not addressing refractive error is not going to have a long-term impact in sight. However, from what I've mentioned, it's obviously makes sense that you have a strong relationship with your optician to ensure that that refractive error is met, and
mm.
if need be, then coming to see an ophthalmologist.
Yeah. And on that note, can you remind people how often they should be seeing a optometrist, optician, um, generally?
Yeah, look, I mean, certainly annually, and if in doubt or this change is afoot or you have an underlying condition, um, more frequently. And I think
Okay.
it's an individual basis. And I have many of my patients who I say, go and see so-and-so sooner.
Mm.
Um, and, sometimes in hospital care and tertiary centres, you don't see the same person.
No.
Uh, and that's inevitable. So continuity is lacking. Whereas locally, you will always see, there's someone who knows you over time, and they
Mm.
can potentially be a little bit more astute at finding any changes that potentially someone who hasn't seen you before might have missed, for example. So I think it's a combination of community and tertiary care in order to maintain the best sites that you can potentially have.
Great. So very quick last question on the health part of it. Can caffeine affect your eye health? And I think they're probably saying too much caffeine in this sort of
Yeah,
scenario, but
yeah. Too much caffeine. We're all guilty of that. Look, I think caffeine is not obviously great for systemic health, for your blood pressure, and as we've alluded to, that you can get hypertensive changes in the eye. So overall, it's not a great thing. When I was an SHO at Chelsea, for example, we saw an interesting, patient who of a syndrome called coffee and donut maculopathy. This patient had too
wow.
much caffeine, developed a visual field defect, which we call a scotoma, in a ring donut type of um,
Oh,
shape.
not because of eating donuts then.
Yeah, Simpson kind of
Yeah.
syndrome, but it was a ring donut type of shape because of caffeine intake. So you have these kind of odd things as well. But
Yeah.
look, the message is don't drink too much caffeine, like you would say too much alcohol,
Of
because
course.
systemic health is very much linked to your eye health.
Mm. Great, thank you. And now, so I've got a couple more questions here. A couple of them probably answer very quickly. Why is it called dry eyes when the eye is wet? Somebody's asked.
Uh, yeah, so when we're explaining this in clinic, you always feel a little bit paradoxical when you're. So bear in mind that the eye tear film is made up of three layers: the very watery layer, the mucus layer, and the fat layer. So the fat layer is made by the lids. There's some glands in those lids, 30 on the top, 15 on the bottom, and they sort of produce the fatty layer of the tear film. If there's problems with the lids or the tear film is not quite right, those that fatty layer is missing, so you have evaporation of the normal tear film. As a consequence, your body compensates to produce more tears because you've got a dry eye, but it's the wrong caliber. It's too aqueous and then it dribbles down your cheek. So the underlying thing would be is to treat the fatty tear film, like we were saying with flaxseed oil, omega-3, lid hygiene, etc., to try to reproduce the correct caliber of tears.
Okay.
But it never made sense to me either.
No, it's one of those terminology things, I think. The next question is just, I think, just a pure interest as somebody. Do animals suffer from the same eye problems as we do? So do they
Yeah,
have the same eye conditions?
yeah.
Okay. And I just want to clarify this. Is it right? So some animals don't actually have maculas, so don't have the same sort of central vision
Yeah, I
that
mean,
we do. And
for example, our, we had a family dog that we were loved, and there was always some kind of like myths about chocolate's bad for the eyes and stuff like that. Essentially, they lacked certain cells of the retina. About cones for color vision, rods for night
yeah,
vision. So to answer your question, they have each animal has a different eye system,
yeah.
and actually one of my old bosses, Nigel Davies, gave me a book to read many years back about the ocular and optic system in different animals, and it's quite
Wow. Yeah.
I don't know where it is, but it's quite a chunky
Yeah.
old. It's quite a readable book, and it's quite interesting. And we have ophthalmologists and colleagues who have done cataract surgery in animals,
Oh wow.
etc. So it's
Oh wow.
yeah.
I think I remember hearing or reading somewhere that eagles actually have two maculas or something like that. Is that? I don't know if you've ever heard that.
No idea.
Hence why they call it eagle eye and they got such good vision. But I think I remember hearing that on some nature program, and there was something about an octopus's eye which was very fascinating, and I can't really remember what it was. But anyway, you're not a vet, so we won't go too much.
I'm not quite sure, so we'll look up together.
Yeah, well, maybe we'll do another series on animals' vision, I'm sure, for fascination.
I'll ask you the questions then.
I'll get Google open. So I'm going to finish on this question because it'll take a little bit explaining as well, if you don't mind. Why do only some people suffer with Charles Bonnet syndrome? And I was wondering if you could answer that, or if you can, and also just explain a little bit about what Charles Bonnet syndrome is to those who might not know or who may be experiencing it right now and sort of don't know why. So
It's a very distressing condition whereby patients have visual hallucinations. So essentially, we've discussed how the normal eye pathway works, whereby light energy is transmitted to electrical impulses to our brain. Now, for whatever reason, if your visual pathway is damaged, for example, let's say you've had a stroke in both visual cortexes in the back of the occipital cortex, or let's say, for argument's sake, both your macula are not working, that input to the brain is missing, right? So what the brain tries to do is compensate by sort of making its own images, essentially, and patients then perceive this as a hallucination. So it's a psychological, psychiatric condition due to damage to the visual pathway. Many patients will describe vividly images, and it's obviously something that is a source of massive distress to our patients, and it's important to recognize it, diagnose it, and help patients through. Unfortunately, there's not that much treatment out there for it. Why do some patients have it and some patients don't? I guess it's to the degree of how much sight loss one has.
okay.
But also, a lot of it is not that fully understood, so it's difficult to answer that question.
Yeah, yeah, of course, and it's one of those conditions which is not talked about as often as it should be, really, and lots of people don't know about it, and probably there's not a huge amount of research, I guess, at the moment into
I think
it.
it's totally right, Mark, and I think because of effectively such a lack of treatment, it's a huge challenge to recognize, diagnose, manage, and treat.
Mhm. I feel what I was saying on that note, if anybody is suffering from Charles Bonnet syndrome or what they think might be, obviously to get in touch with us. There are support groups out there, and actually sometimes just talking to others who have it actually really helps people. From our
I think that's such an important point, and that's one of the things I love about working with the OAB and go down there and we work together, is that it's recognizing that it's not just an eye, it's a person. And I think the psychological impacts, and when we've had sort of meetings with our friends like Susan from the from the psychology department in Oxford, I think that cannot be underestimated.
Brilliant. I think we're going to finish there, Gurjeet. I just want to say a huge thank you for taking the time out to answer people's questions. I know you're so busy, so thank you so much for taking that time. I think we'll probably do it again sometime. So, if people are watching this, please leave questions maybe in the comments below, and we'll have another session at some point. And if anybody does have any questions about obviously coping with their visual impairment, adapting, any of the services, obviously in Oxfordshire we're based, give us a call. We'll put all the details with the video. Do contact us because we're always there to help. And if anybody has any other eye health related questions, we can put them for another time. But thank you, Gurjeet. It's been brilliant.
Absolute pleasure. Thank you very much, and I hope everyone's staying safe. I just want to leave a message of what we're all trying to do: social distancing, wear your masks, ensure you're washing your hands, and please stay safe.
Thank you. Brilliant. Thanks, Gurjeet.